One of the things we're going to talk about today is healthcare finance. And a phrase that I talk about in class and that I'll talk about with you that you really need to keep in mind is funding equals function. So what that means is whoever funds it and how they determine to fund or reimburse determines what gets done. And the system has moved out through time to change a little bit, but we still have almost 20% of GDP as our healthcare costs, so there's still issues with it. Even under the Affordable Care Act, we've reduced the increase, but the increase still occurs. One of the first things you need to think about, though, is that the demand for healthcare is driven by how it's paid for. And that's kind of a new concept for a lot of people. Increased demand means that you will have more utilization of healthcare services if you have enough people who can supply it. So if we give more people insurance and insurance covers certain things, then you will have more people using the system, which is one of the reasons why with the Affordable Care Act, we were afraid that there wouldn't be enough doctors or providers, mid-levels, etc., when we had so many new people in the system. That hasn't happened yet, but we think that it might eventually, which is why we're sort of pushing on the education front to get enough providers and mid-levels to deliver the services for the people who have insurance. Health service managers are typically guided by sort of the demand side, which means who's going to reimburse it, what kind of services will be offered based on that reimbursement, and the management decisions at the hospital, the practice, the individual provider is always based on what will be reimbursed. So will we renovate the part, like for instance, most hospitals have a really great neonatal and labor and delivery, because that will be reimbursed either by Blue Cross Blue Shield or Medicaid. So they know they're going to get the money. So that is going to be beautiful, even if the rest of the hospital's not, because they want to entice people to use that because that's what gets reimbursed. You only buy stuff that you know will be reimbursed. So again, that funding determines what you have, and that determines what people have access to, not what the need is. So think about how that sort of plays out. New technology is going to be rapidly disseminated and used if it's reimbursed. MRIs, CT scans, probably overused, but in part because most people who have third-party payer insurance from their employer, that'll be reimbursed. And if it's reimbursed, then we're going to use it, whether it's medically sound or we should or not. So that is part of what's happening with you need a happy medium, and we haven't gotten there yet. Now, there's different types of insurance, and I want to make sure everyone understands the difference. And the function of insurance is because we can't figure out when you'll need it, right? So the risk has to be acceptable, and someone has to offset the risk. So what you're doing is you're transferring the risk from you as a person to a group of people through your employer, right? In case something really goes badly. There's group insurance, and that's the kind that most people have through their employers. And that risk is through the entire group, like I said. So if you get sick, it's not all on you. Everybody else is paid in a certain amount. They don't get sick, so you can use some of that money for yours. So that's how the insurance companies see it, so they'll still make a profit. Then there's self-insured, which is a little bit more difficult because you can't spread the risk out, and some of that depends on the pool of people you're in. And then there's the individually purchased for the self-employed, and that's sort of like what the Affordable Care Act helped to bolster up some of those independent people so that they would have enough money to provide and get health care. Then there was managed care plans. Now that was in response to the healthcare costs going way overboard and just people couldn't keep up with it. And what managed care did was it sort of, and a lot of it was insurance companies, is it really helped keep the costs down by controlling a lot of the factors that drove cost up. But we'll talk more about that later, and that's also a whole nother chapter. One of the things to keep in mind is the difference in how they rate whether or not people should get services or not. And most plans will do things like medicine and surgery, but they didn't do preventive health care. And one of the things that is also usually left out is dental care and eyeglasses. So a lot of stuff that you're like, people really need wasn't covered there, and things like preventive health, which would have made the cost lower eventually, right, wasn't in there. So if it's not in there, the doctor's not going to provide it for you. Again, what's paid for is what gets provided, not what's needed or what's medically required. And that's a huge difference between us and somewhere like Great Britain that has a global budget that looks at what's the need, and then that's what gets provided. So we sort of do it the other way around. One of the things to keep in mind too is that you want to have a good community rating, and that's when you spread it out towards an entire group of people. It establishes the premiums based on utilization of a whole community, and that's sort of what happens with third-party players. They do it throughout your entire group of people that they're insuring. This helps subsidize the people who are in poor health with people who are in good health. One of the things about the Affordable Care Act that we'll talk about later is that one of the reasons you wanted the young, healthy people is because they wouldn't really use a lot of their insurance, and that would help offset the people who had pre-existing conditions. Now, then there's the government part. And the government part is Medicare and Medicaid. And Medicare has 4 parts. Part A is if you get hospitalized, if you need specifically outpatient services, no. This is just hospitalization, and it's for a brief period. You might get some skilled nursing facility, but for a very limited time. That's what that covers, and there's no out-of-pocket fee for you. So if you're not very rich, that's what you get. But again, if that's all that gets paid for, then you will get your health care from a hospital versus other places which you're going to have better outcomes. So that's a problem built into that system of what's reimbursed. The second part is Part B and Part C, which are sort of cost sharing, and you pay, the individual who has Medicare can pay for extra things. So they might pay a sort of extra insurance, and that helps them offset the cost and expand what they can have access to. But again, that's out of pocket for them that they have to pay for, that they may or may not use. And Part C was so that we could have more of a managed care approach, so that there would have to be some oversight and some continuity of care and some utilization issues. Part D is the newest, and that covers prescriptions. However, it's not all prescriptions, because there's a point where things are covered and then they're not, and that's called the donut. And during that part, a lot of older people cannot find and cannot get access to those medications. One of the problems with this, and Medicare is sort of this perfect example, is people are going to use what's covered, and then whenever you get to that donut, they're going to not use their medicine as much. So you're going to get negative outcomes because people can't afford to buy things and do things, right? Preventive health was not covered in the stuff that was free because it's just the hospital. So you have people who have diabetes, they're going to get worse, go to the hospital, get out, then they can't afford the medicine and the health care and the doctor visits, so they're going to get sick again, or they won't take them in a regular way because they can't afford the cost and the follow-up for the doctor, and then they end up back in the hospital. So you end up with some really unintended consequences from the way this program is set up. Now, Medicaid is very, very different. Medicaid, you don't get automatically when you're 65 or 63, depending on how old you are. It's a means-tested program, and means-tested means that eligibility is set by each state. So the threshold of income is set by each state. And what happens is that the government and the state pay for a certain percentage of it. Also, the problem with Medicaid is that you can qualify now and then later not. So you can sort of go in and out of the system. It was originally set up for women and children. Now a large portion of it is used by older people to cover nursing home care. So that's not what the intent was, but because people can spend down or qualify for it, it pays for that kind of care. Again, better state like New York, they are going to pay 50% at a larger amount and have a sort of, you can make a certain amount and then a higher amount and still get it covered. Not the case with Louisiana, where people are actually sicker and there's not as many providers. So again, this system sets up inequalities and it keeps those in place. And that is a problem, especially if you want continuity of care and if you want specific standards. One of the things you do need to keep in mind is that there's a lot of bad financial incentives built into healthcare financing. One was fee-for-service. This was before managed care, which the doctor would get paid whether they improved your quality or not, and they would get paid for every visit. So they would bring you in a lot. They might overtreat you, and they might say each service would be billed separately. I know some of you have seen that on your insurance bills because they're going to get paid for it separately, right? So it's that really bad incentive to make sure that people were overcovered, overcharged, and they didn't need it again. So that was one of the things that managed care was trying to do away with and to establish a cap on. But we will talk more about that later. Trust me, much more about that later in a separate sort of little mini movie. One of the things to keep in mind, though, about healthcare costs is that these are problems that have been around a long time. and they're not going to go anywhere until we decide how to pay for it and to make sure we're paying for quality and what is needed versus what is funded. And that's going to require all the players to sort of come on board or come to some consistent idea of what those things are.